Hello, everyone. My name is Francois-Clement Bidard. I'm a medical oncologist working at Institut Curie in France. Today, we will look at a case which is about optimizing treatment selection and how to make appropriate sequencing decisions for patients with ER-positive, HER2-negative metastatic breast cancer previously treated with CDK4/6 inhibitors. So here's a case. Monica Lee is a 54-year-old postmenopausal woman. Her medical history includes well-controlled hypertension, osteopenia, and a BMI of 29. Her family history includes her father prostate cancer, which was diagnosed at age 80. In June 2021, she presented at the clinic with a mild fatigue. Biopsy and imaging results revealed a grade 2 invasive carcinoma of no special type in her left breast. Biopsy revealed an hormone receptor positive to negative status. CT scan and BOS scan revealed a multiple bone lesion. First-line treatment consisted in a combination of letrozole and ribociclib with a good response, clinical and radiological improvement in breast and axilla, while bone lesions were densifying. 2 years later, Monica presented with a new liver metastasis and additional lytic bone metastasis, while breast and axillary lesion remained stable. So, based on this case, what are the needed molecular investigation and what would be your treatment decision? Starting with molecular investigation, we'd like to remind that we have stable breast cancer characteristics and labile breast cancer characteristics. Stable characteristics are unlikely to change over time throughout a patient primary diagnosis, possible relapse, or progression under CDK4/6 inhibitors. These stable characteristics are often clonal genetic abnormalities which drove the early oncogenesis. They could be grouped into three categories currently not targetable, such as somatic TP53 mutation, currently targetable as per labels, such as somatic mutation in PIK3CA or germline mutation in BRCA1 or BRCA2, and also there are a few abnormalities that are deemed currently targetable but off labels that I will not discuss here. Now, moving on to the label characteristics. So these are the proven variable characteristics that may change over time, and most common mechanism of resistance consists in mutation appearing in the estrogen receptor gene, ESR1. This mutation leads to resistance against aromatase inhibitor in metastatic stage. Prevalence of this ESR1 mutation changes across disease stage. These mutations are detected in less than 1% of primary tumor, about 3% of relapsing tumor, and 40% during progression under aromatase inhibitor. ESR1 mutations are typically assessed using NGS or ddPCR. These molecular assays could be performed on either tissue and or liquid biopsy. In terms of liquid biopsy, the preference goes to ctDNA, which serves as the gold standard for liquid biopsy as per ASCO 2023 updated guidelines. The advantage of liquid biopsy is that this test is less invasive and offers faster results compared to tissue biopsy. It boasts an excellent specificity, minimizing false positive results, and exhibits good sensitivity, although imperfect between 80 to 90%. False negatives are primarily observed when tumor burden is limited or when tumor progresses slow. Tumor displays a positive response to therapeutic intervention. In other words, ctDNA analysis is to be performed at time of tumor progression. Now back to Monica's case. The archived primary tumor tissue showed no PIK3CA mutation, no germline BRCA mutation. A rebiopsy of the breast tumor at progression letrozole and ribociclib confirms the tumor as estrogen receptor positive and HER2 negative, while ctDNA analysis uncovers the presence of an activating ESR1 mutation. So what are the available current treatment options for patients like Monica? First, we could exclude immediately chemotherapy. There is no visceral crisis, fulvestrant and alpelisib, there is no PIK3 mutation, and PARP inhibitors, there is no germline BRCA mutation. In guidelines, but that could be seen as suboptimal. We know that fulvestrant single agent yields to very short PFS and AI plus everolimus because ESR1 mutation is definitely calling for a third as endocrine therapy partner. What could be seen as optimal therapy could be fulvestrant plus everolimus combinations. This combination could be used in all comers, but there is no phase 3 data to substantiate the benefit of this combination. And there is the option of fulvestrant plus a switch of CDK4/6 inhibitors. We know it is likely less toxic than everolimus combination, but there is only small phase 2 data with mixed results. Elacestrant is also another treatment option to consider. In the Emerald trial, elacestrant demonstrated a higher PFS rate versus standard of care endocrine therapy at 6 and 12 months in patients with ER plus HER2 negative advanced breast cancer following prior CDK4/6 inhibitor therapy. This efficacy was especially pronounced in patients harboring an ESR1 mutation. On the basis of Emerald, FDA approved elacestrant in January 2023 for postmenopausal women or adult men with ER-positive HER2 negative ESR1 mutated advanced or metastatic breast cancer. Emerald showed that the toxicity of elacestrant is comparable to other standard of care endocrine therapy. Most common side effects, including nausea, fatigue, and vomiting of all grade, while the most noticeable grade 3-4 adverse events including nausea, back pain, and ALT increase. I would like to thank you very much for your attention, and please refer to the attached slide deck for more information.